Hi everyone, join us for our engaging NCLEX review session. Now we are on day 69 out of 90. So we are inviting you to enroll into our NCLEX review course at Stancoast NCLEX Coaching. We are offering about 3,000 NCLEX-style questions plus 20 hours of animated videos, 200 hours of on-demand lectures available 24/7 for 6 months. And we also have the 200 NG test questions. So kindly visit our website to learn more. And for further information, click on the link below and kindly type in your comments. We value your input, so feel free to give your feedback or questions in the comment sections and we'll be happy to help. And also don't forget to hit the like button and also subscribe to our channel and share this video to your friends. Now let's have a drill on type 2 diabetes mellitus NCLEX questions. So let's get started. Question number 1. A patient undergoing diabetes screening at the clinic has a fasting plasma glucose level of 120 milligrams per deciliter. What should the nurse focus on when educating the patient? Is it A, checking blood glucose levels at home, B, starting low dose regular insulin therapy, or is it C, making lifestyle changes to lower blood sugar levels, or D, understanding how oral diabetes medications work? Take note, you are taking care of this patient who is undergoing the screening and now has a fasting plasma glucose of 120 milligrams per deciliter. So when you are going to start educating this patient, what would be your focus on? Would that be letter A, checking blood glucose, or is it B, starting low dose regular insulin therapy, or is it C, making lifestyle changes to lower blood sugar levels, or is it D, understanding how oral diabetes medications work? If you had answered letter A, checking the blood glucose levels at home, this is incorrect. We know that self-monitoring of the blood sugar is very important for those diabetic patients in order to manage their blood sugar levels. However, your patient this time is actually a pre-diabetic. So self-monitoring this time is not typically necessary. So take note, your patient is pre-diabetic. All right. Take note about the fasting blood sugar of 120 milligrams per deciliter. We're not going to do this yet. All right. What about letter B? Starting low dose regular insulin therapy. Well, as a pre-diabetic patient just being diagnosed right this time, the insulin is typically reserved for those patients with type 1 or those with advanced type 2 diabetes. So this is not our direction of care at this point. If you had answered letter C, making lifestyle changes to lower blood sugar levels, this is the correct answer that we are looking for. As the patient is still pre-diabetic, we are going to encourage them to commit in doing lifestyle modifications. It could be dietary modification and also encouraging them to do some more exercises to prevent the progression to type 2 diabetes mellitus. So correct answer is letter C. If you had selected letter D, understanding how oral diabetes medications work, again, this is already in the action phase or implementation phase. I mean, you're educating this time, right? But these are the oral hypoglycemic drugs that are going to be prescribed in those patients that are already diabetic, not for patients who are pre-diabetic. So the primary intervention for this patient would be lifestyle modification. That would be the initial modification. That's the initial step in treating this patient. Let's have number 2. A 55-year-old female patient with type 2 diabetes and a BMI of 31 kilograms per meter squared is being assessed by the nurse What is the most critical goal in her care plan? Is it A, achieving a hemoglobin A1C below 7%, or B, following a diet and exercise program to lose weight, or is it C, choosing meals that evenly distribute calories throughout the day, or D, explaining the importance of avoiding simple sugars in her diet? Hello, everyone. For those who just joined in our session, welcome. Your patient is type 2 diabetic with a BMI of 31 kilograms per meter squared. And what would be the most critical goal in the care plan? Would that be A, is it B, C, or D? If you had answered letter D, explaining the importance of avoiding simple sugars in her diet, explaining the importance, would that be the most critical goal for this patient that has a BMI of 31 kilograms meter squared with a type 2? We know that the dietary education is very important, right? And avoiding the simple sugars is part of that regimen. But the ultimate goal or aim is to maintain a good glycemic control, which is letter A. That is the most important aspect, especially that your patient has a BMI of 31 kilograms. Why? The reason for that is they are actually overweight, actually in the obese, right? The patient around this time is basically going to have elevations in their blood sugar, and that would be the crucial part in their treatment. We want to make sure that they're going to achieve that healthy glucose levels at this target range below 7 to prevent the complications. That would be the primary and also the critical goal in this patient. Okay, again, the goal is to avoid complications or prevent complications from the hyperglycemia. Even though the letter B states following a diet and exercise program to lose weight, it sounds really good, right? But this is not specifically targeting the goal of maintaining a healthy range, which is basically below. B is not going to achieve the goal in A. Yeah. Is answer B not going to achieve? It will. But if you are going to really want to have at least a more specific goal, we want to get this going for this patient. At least they have something to look forward to, that particular range. That should be the aim for this patient. If you had answered letter B this time, we know that weight loss is important for overall health, which is basically part of letter A, right? It can help the management for this patient's hyperglycemia, but controlling their blood glucose levels is much more critical to prevent complications. Following a diet and exercise program to lose weight is just one aspect or two aspects in the management of type 2 diabetes. There are so much more, and this is not really encompassing for all those treatment or modifications. So letter A would be the most specific answer to this question. Basically, we need to have them know that, hey, you really need to accomplish this within this time frame. You need to get this goal for you. Okay, so that is the rationale why we are checking in, or why we are selecting letter A this time. All right, letter B is not, it doesn't encompass all those modifications. All right, while letter A, it is basically that goal that would prevent the complications, because we know that hyperglycemia can lead to chronic complications. All right, letter number 3, rather. A diabetic patient undergoing an exploratory Laparotomy for abdominal pain needs interventions to support wound healing. What should be the nurse's priority or top priority? We know that A1C, yes, that's correct. A1C. All right, let's get going to number 3. A diabetic patient undergoing an exploratory laparotomy for abdominal pain needs interventions to support wound healing. What should be the nurse's top priority? Is it A, keeping blood glucose levels within normal range, or B, ensuring adequate protein intake through diet, or C, administering antipyretics to maintain body temperature below 102 degrees Fahrenheit, or D, applying a sterile dry dressing to the surgical incision twice daily? Your diabetic patient is undergoing this major surgery for the abdominal pain. So in order to support the wound healing in this patient, what would be your top priority among the 4? Would that be letter B, ensuring adequate protein intake through diet? Or would that be A, or is it C or D? Now let's tackle letter D first. Alrighty, what is in letter D? Applying sterile dressing, dry dressing to the surgical incision twice daily. We know that the dressing changes are very important, right? Post-op. This is to maintain wound cleanliness. But the dressing alone, I mean, it's not really going to require twice daily. This is a bit much for a post-surgical, first intention type of surgical procedure. But the systemic factors, let's say the blood glucose control, can significantly affect the healing. We know that without proper glucose control, if your patient's glucose is mainly congregating in the bloodstream, if it's not really controlled, like if there is no proper delivery of the glucose into the cells, then what's going to happen? There's going to be poor wound healing, right? We need to make sure that we are going to control this by making sure we are monitoring the patient's blood sugar, treating that with possible oral hypoglycemic agents, or could be insulin, to make sure that the glucose will be delivered into the cells. That's the nutrition to the cells, right? If there is hyperglycemia, what do you expect? If the tissue has that incision, right? Surgical incision, it will not really heal properly. So the goal of our treatment here is to keep the blood glucose levels within the normal range. If you answered letter B, we know that protein intake through the diet is very important, but without controlling the glucose, even if you're going to give them optimal protein nutrition, it still cannot overcome the negative effects of the hyperglycemia on the healing. This is important. However, glucose control should take priority this time, as we know that with excess glucose in the vascular system, it's not going to get delivered into the tissues properly. It will not promote wound healing. So we are going to select letter A instead of letter B. If you had answered letter C, administering antipyretics, would that be able to control the patient's blood sugars? I doubt. It will only promote comfort for those who are having fever or maybe some for mild pain, but it doesn't really impact on the wound healing. Okay. Take note, guys, our patients with diabetes mellitus, if we are not controlling their blood sugars, they're going to be prone to complications such as the dehiscence or the evisceration of poor wound healing. Dehiscence and evisceration. Take note, guys. Blood sugar control is of utmost priority. Let's have number 4. A patient with diabetes on insulin therapy is scheduled for knee replacement surgery and has been NPO since midnight. What should the nurse do? Is it A, skip the usual insulin dose since the patient is NPO? Or B, check blood glucose levels before administering any insulin? Or C, administer the full insulin dose as stress may raise blood sugar? Or D, give half the usual insulin dose since the patient isn't eating before surgery. So you are the surgical nurse or the nurse assigned to this patient in the unit and has been NPO since midnight for the knee replacement surgery. What you should do here as the AM shift nurse, will you do A, or will you do B, or C, or D? All right, let's get started with the rationals. If you're going to do letter A, skip the usual insulin dose since the patient is NPO. If you're going to withhold the insulin without assessing the blood glucose levels first, this might cause hyperglycemia to your patient. We know that stress in the form of a surgical procedure can really impact their blood sugar levels. So just withholding it without assessing is some form of a neglect. We are going to eliminate letter A. If you answered letter D, give half the usual insulin dose since the patient isn't eating before surgery. Is that going to be your decision this time? Just giving half? We know that the requirements for the blood sugar, the requirements for the insulin use can vary. But if you're just going to reduce it without checking the patient's blood sugar first, this can also lead to improper glucose management. Half the usual dose? Without checking? Nope. You should check first the blood sugar before deciding to skip or to give half the dose. If you are going to administer the full insulin dose as stress may raise the blood sugar, you're actually skipping the assessment part, which is very critical. You need to have that baseline information before administering the insulin. This can result to hypoglycemia, especially if the patient is NPO. We know that stress can cause hyperglycemia, but it would be safer for you to assess the sugar first thing before you're going to have to administer that prescribed full dose. So we don't have any other option but letter B, check blood glucose levels before administering any insulin. Never administer insulin without checking the more recent value. And take note, guys, that when you are administering the insulin, this is a critical medication that you should be checking with another nurse. When you are going to check the blood sugar of the patient and if you have an order to, let's say, give that exact dose according to the sliding scale, if you are going to administer, let's say, Humalog or Novolog, once you calculate the dose, you want to make sure that the dose is also counter-checked by another nurse. And this is one of the best practices, and this is something that is ideal in all settings. Make sure that this is counter-checked by another nurse, not just you checking the dose, but it has to be checked by 2 nurses before administering. Now let's have number 5. A hospitalized patient with diabetes is frustrated about their blood sugar being higher during illness despite dietary control at home. What is the nurse's best response? Is it A, the liver struggles to process glucose during stress? Or is it B, the hospital diet likely contributes to higher glucose? Or is it C, stress from illness causes hormone release that raises blood sugar? Or D, it's just a coincidence that your glucose is higher when you are sick? Your patient is frustrated because no matter what they're doing with that prescription, when they are administering that or hypoglycemic maybe, or an insulin for their blood sugars, it's not really being controlled. I mean, it's not about the insulin or oral, but actually with the dietary control. So it didn't say anything about the insulin or the oral hypoglycemic. So what would be the explanation to that? Even though they are really trying hard to maintain a healthy diet, despite dietary control at home, what is the explanation why they will end up with higher blood sugars? Is it A, the liver struggles to process glucose during stress? Is it really? Well, to explain this, letter A, well, the liver doesn't have an impairment in glucose metabolism during stress. However, the liver will produce more glucose due to the stress hormones. This is incorrect. There is no liver impairment, but instead, the liver will be forced to convert those stored glucose into, other sources to convert it into glucose, because it is responding to the stress hormones. Basically, that is letter C. Yeah, remember about the hormones that actually will stimulate the production of the blood sugar, or the breakdown of the glycogen, or the conversion of the other sources into glucose. Remember that. So the hormones that we're talking about here are the cortisol, epinephrine. Cortisol, epinephrine. These are the known hormones that will stimulate the liver to produce more glucose. Okay? Yeah. Steroids are relieved during stress. The cortisol alone can lead to the hyperglycemia, plus the epinephrine. Again, this will lead to increasing production of the glucose by the liver. If you had answered letter D, it's just a coincidence that your glucose is higher when you're sick. It's not a coincidence. It is the processing that is innate in the body. The high blood sugar during the illness is not coincidental, but it is due to the body's stress response. Letter B, the hospital diet likely contributes to higher glucose. You think that's the reason? Not really. Hospital diets are typically calculated, right? They are going to be, what do you call this? They are, yes, calculated in order to manage the patient's blood sugar levels, especially for the diabetics, okay? And so our final answer here would be about the stress hormones that will be released in response to the stress. That is letter C. And the same goes when you are going to encounter a patient that has the Cushing's syndrome. They will have elevation of the cortisol, right? The same will happen when they have the Cushing syndrome. There will be overproduction of the glucose by the liver because of that cortisol. Let's have number 6. Which statement by a nurse is accurate for a patient newly diagnosed with type 2 diabetes? Is it A, insulin is not required for managing type 2 diabetes? Or is it B, type 2 diabetes complications are less severe than those of type 1? C, lifestyle modifications can help control blood glucose in type 2 diabetes? Or letter D, type 2 diabetes is often diagnosed during a hyperglycemic coma hospitalization. Which of those statements is accurate for a patient newly diagnosed with type 2? Let's eliminate our options here. If you had answered letter A, insulin is not required for managing type 2 diabetes, mark that as incorrect already. This is actually needed or maybe necessary for some patients with type 2, especially if their oral hypoglycemic medications, or let's say if their lifestyle changes do not, if they are not sufficient, then the medical provider may add the insulin therapy for these patients. Okay, not required. That's a wrong statement. What about letter B? Type 2 diabetes complications are less severe than those of type 1. Is there truth to that statement? We know that both type 1 and type 2 diabetes have pretty much the same degree of complications and the same level of seriousness. They will have the neuropathy, they will have nephropathy, and also the cardiovascular issues. So if you're picking this option, less severe, nope, that's not quite true. Again, the same complications will arise. Nephropathy, which is going to involve the degradation of the kidney function. We also have the neuropathy, which can impair the function of the nerves, either autonomic or it could be peripheral neuropathy, and also cardiovascular issues. Could be atherosclerosis, hypertension as well. All right, so this is incorrect. What about letter D? Type 2 diabetes is often diagnosed during a hyperglycemic coma in hospitalization. Really? Up to that point that the patient is going to be comatose? Now, type 2 diabetes is usually diagnosed through routine screenings or maybe symptoms, not typically hypoglycemic or hyperglycemic crisis. So we are deselecting that one. We have letter C as our correct answer, which is lifestyle modifications can help control blood glucose in type 2 diabetes. The patient here in type 2 diabetes still have some residual pancreatic activity. They're still going to be able to release some insulin. However, they would need additional medications such as the oral hypoglycemic agents, or it could be lifestyle changes. And if those two are not sufficient, then insulin can also be used on top of those other, those two interventions. So the correct answer here is the letter C. Let's have number 7. After administering aspart, which is Novolog, insulin at 8 a.m. to an adult male patient, when should the nurse be most vigilant for signs of hypoglycemia? Is it A, 10 a.m., B, 12 p.m., C, 2 p.m., D, 4 p.m.? So this is reduction of risk potential type of question. When would you be much more vigilant, or what exactly the time here that you should monitor your patient for any signs of hypoglycemia? Would that be A, B, C, or D? So your clue here is to recall what type of insulin Novolog is. Is it a rapid acting? Is it intermediate? Or is it a long acting type of insulin? What do you think about this type of insulin? Okay. If you had answered letter D, 4 p.m., take note that your patient received the dose at 8 in the morning. The clue here is to actually identify the time. You need to know the peak time of the Novolog insulin. If you had answered letter D, 4 p.m., this is incorrect. The medication around this time is no longer active. And so this is kind of late to observe the hypoglycemia already. So, no, this is way past of the Novolog's peak time. If you had answered letter C, 2 p.m., so how many hours is that? 9, 10, 11, 12, 1, 2. So that is 6 hours. That's basically the duration of action, 6 hours. So if you had answered letter C, the risk of the hypoglycemia around this time is low at 2 p.m. because the effects of the Novolog has already been diminished, right? So this is incorrect. Now, if you had answered letter A, 10 a.m., that is only 2 hours after the administration. This is the peak time. We know that the peak time of the Novolog is somewhere between 1 to 3 hours after it has been injected. So the 10 a.m. is the most critical time for you to follow up your patient. Ask them if they are feeling shaky, if they feel somewhat kind of agitated, or if they feel lightheaded. You got to ask them those questions. All right. This is the peak hour of the drug. If you had answered letter B, 12 p.m., which is what, 4 hours after the administration, the peak of the drug this time has already faded, right? It is already past, it's past the time where it's supposed to be on its highest concentration. So this is not really the time to check for the hypoglycemia. It has already passed, guys. So take note about the peak time. This is the most critical period that you should be evaluating your patient. You got to make sure that you're assessing them or evaluating them for any signs and symptoms of hypoglycemia. And if you are going to, if they're going to say, yeah, I feel like lightheaded right now, I feel so hungry, I feel so agitated, I feel so shaky, then do a spot check on their blood sugar to evaluate if they are within that safe range. If they are already hypoglycemic by this time, then you got to do your nursing judgment. You're going to have to probably give them those maybe rescue simple sugar, or it could be maybe a simple snack. All right. So it will be dependent on how low the blood sugar can be around that time, especially for the newly diagnosed diabetic patients. Sometimes they're so naive that they will drop significantly. All right, let's have number 8. What should a nurse include when educating a patient with type 2 diabetes about glyburide? Is it A, glyburide reduces glucagon secretion from the pancreas? Or is it B, glyburide increases insulin production and release from the pancreas? Or C, glyburide should still be taken even if morning blood sugar is low? Or D, glyburide must be avoided for 48 hours following IV contrast media? Oral hypoglycemic drug. Let me just call that as OHD. Hypoglycemic drug. So what would be your education at this point? If you had answered letter A, glyburide reduces glucagon secretion from pancreas, this is incorrect because it doesn't impact the glucagon secretion. It doesn't. What it can do is to stimulate insulin release. Glyburide stimulates insulin release. It doesn't have an impact on the glucagon, right? So we are marking that as incorrect. If you had answered letter B, glyburide increases insulin production and release from pancreas. We know that is the action, right? This is a sulfonylurea. They are going to stimulate the pancreas to produce more and to release more of insulin. So it will have that therapeutic effect in reducing the blood sugar. This is the primary drug action. Stimulates insulin release. Okay, that's the correct answer. If you answered letter C, glyburide should still be taken even if morning blood sugar is low. Wow. If the blood sugar has been low already, this can further decrease the patient's blood sugar. So, if you are the nurse in this scenario, when you are educating them, make sure that they understand the mechanism of the drug. They should be checking their blood sugar first. If their blood sugar is low, they should refrain from taking this medication. Okay? Or it would be wiser to make sure that they are checking with their medical provider if it is in the home setting. But more oftentimes, the medical provider will not let them take this medication if their blood sugar is low. We are not selecting this answer. What about letter D? Glyburide must be avoided for 40 hours following IV contrast media. This is not this medication that will be withheld or avoided within 48 hours, not glyburide, but rather metformin. Okay, not glyburide. The glyburide doesn't really have the interaction with the IV contrast, but metformin can. All right, it can lead to insufficiency in the kidneys, renal insufficiency. So we'll talk more about the metformin in the next few minutes. So the correct answer for this test question is letter B rather. Glyburide increases insulin production and release from the pancreas. Please don't forget that. All right, number 9. A nurse has been teaching a type 2 diabetes mellitus patient about managing blood sugar with glipizide, or known as glucotrol. Which statement by the patient indicates a need for more education? Is it A, I'll still take my usual dose if I eat too much? Or B, other medications might affect my blood sugar? Or C, I might need insulin if I get sick? Or D, I won't get complications since I don't need insulin? Needing more education. So you're going to spot that incorrect statement made by the patient. If you answered letter A, I'll still take my usual dose if I eat too much. This is generally appropriate, as it will still help maintain a steady blood sugar. And so we are not going to select this one. If you had answered letter B, other medications might affect my blood sugar. Yes, there is truth to that statement. It simply means that they have the awareness that other medications that they might potentially be taking can also interact with the glucotrol. It might affect their blood sugar. It could be high or it could be lower blood sugar. If they stated, I might need insulin if I get sick, this is also a statement that is actually, it signifies that they are understanding the nature of the disease. If their glucose is not controlled by the glucotrol, then they're going to require, or they might need insulin especially during times when they are being stressed, right? All right, let's have letter D. That's the correct answer. I won't get complications since I don't need insulin. Very false statement. The complications from type 2 diabetes can occur regardless of the insulin use, and that we know that the glucose control is always the key to preventing the complications. All right? Not true. Correct answer is letter D. Very good, guys. Very good. Always think about a patient that is hospitalized. That's already enough stress to them. And so most often, if they are diabetic, type 1 or type 2, their blood sugars will skyrocket. You got to keep monitoring their blood sugar as prescribed, and make sure that you're going to have to communicate with a medical provider if you are seeing a trend in their blood sugar spiking. Despite the doses that they have been given, probably they're going to need additional doses, especially insulin, so that their blood sugar will be managed better. Number 10, a diabetic patient on metformin develops a rash from an unknown cause prescribed. Let me reread that. A diabetic patient on metformin develops a rash from an unknown cause prescribed prednisone. What should the nurse anticipate? What's this? 1456. Is it A, a need for a higher calorie diet when on prednisone, or B, the development of hypoglycemia while taking prednisone, C, the possible need for insulin while on prednisone, or D, rash development from metformin prednisone interaction? Let me restate that question because it's kind of like awkward. 1456. Rash from prednisone prescription. Okay. Your answer, please. Nice. Very good. You're thinking. If you answered letter A, a need for a higher calorie diet while on prednisone, we know that prednisone is already going to lead to hyperglycemia. So if we are going to add high calorie diet, then this is not going to help the patient at all. This will worsen their hyperglycemia. Prednisone. This will lead to hyperglycemia. Right? There's no need for us to increase their calorie. This will worsen their condition. If you answered letter B, the development of hypoglycemia, what should the nurse anticipate? The development of hypoglycemia while taking prednisone. This is the exact opposite. Not hypo, but rather hyperglycemia. We know that, right? Yeah. If you answered letter D, rash development from metformin prednisone interaction, rash development, it's not really caused by that. There's no known interaction between the two, metformin and prednisone. So this explanation is very unlikely for the scenario. So if you answered letter C instead, the possible need for insulin while on prednisone is going to be the correct answer. This is known to increase the patient's blood sugar. So at this point, they will require, or they might need, insulin to better control their blood sugar at this time. Okay? especially for those patients that has diabetes, and if they are having, let's say, COPD exacerbation, and if they're going to be the same thing with the use of prednisone in this scenario, they are getting a prednisone prescription in treatment of this rash. The same thing will happen when they are given the steroid-based medications when they have COPD, methylprednisolone, prednisone, or let's say when they're given a prescription of steroid when they have pneumonia, when they're admitted. Yeah, the same thing can happen. This will really cause hyperglycemia, adding to their pre-existing diabetes. So definitely we need to treat that with that insulin, a possible treatment that can be added to their regimen. So the correct answer for item number 10 is letter C. Let's have number 11 this time. Again, guys, we are inviting you to enroll in our NCLEX course via website, so kindly check the link below. Now, number 11, a patient with type 2 diabetes who is unresponsive is brought to the ED and diagnosed with hyperosmolar hyperglycemic syndrome, or known as the HHS. The nurse should be ready to A, administer a 50% dextrose solution, or B, infuse IV fluids with normal saline, or C, provide oxygen therapy via nasal cannula, or D, give glargine insulin. We have the HHS in this patient with a type 2 diabetes. So what would be that action that you should be ready to implement in the ED? If you had answered letter D, Lantus or glargine insulin, for you to eliminate this option, you got to identify what type of insulin this is. This is a long-acting insulin. Your patient with the hyperosmolar hyperglycemic syndrome is experiencing osmotic diuresis, right? There's way too much glucose spilling from their kidneys because their renal threshold level has been overwhelmed. So they will have the polyuria causing hypovolemia. And the reason for that is because they have hyperglycemia. The Lantus insulin will not treat that one, especially in the acute setting or in the acute, during the immediate phase. The patient will not really benefit from a long-acting insulin. They will respond instead to a short-acting, right? Such as the regular insulin. So we are going to eliminate letter D. It's not going to be helpful for this patient. If you are going to do letter C, provide O2 therapy via nasal cannula, is there really a need to give that patient oxygen this time? There's no signs of hypoxia, so it's not really indicated in this scenario. We are eliminating that one. If you answered letter A, administering a 50% dextrose solution, this can worsen the hyperglycemia. We are going to treat their high blood sugar levels instead, not add more blood sugar or not add more sugars in their system. So what you should do here is to infuse IV fluids with normal saline. Boluses. We are talking about boluses. Liters upon liters of normal saline, because they are going to be possibly going to be in shock, hypovolemic shock. Or they are probably in this state already, right? The patient is unresponsive. Yeah. So we need to establish, or we need to reestablish their circulation. That is an issue for this patient. You got to prioritize the normalization of their circulating fluid volume in order to facilitate perfusion to the body organs. Make sure that it is maintained. Hemodynamic stabilization. All right, that is letter B. Let's have number 12. What should the nurse teach a female patient with a peripheral arterial disease, type 2 diabetes, and sensory neuropathy in her feet and legs? A. Opt for flat-soled shoes made of leather. B. Use heating pads on low heat settings. C. Apply callus remover to corns and calluses. Or D. Soak feet in warm water for 1 hour daily. Your patient has peripheral arterial disease, type 2, and has sensory neuropathy in both feet and legs. If you answered letter D in this question, soak feet in warm water for 1 hour daily, what can this lead to? If you're going to let them soak their feet in warm water for 1 hour, this is going to lead to the skin maceration. 1 hour soaking can lead to the maceration of their skin. And with that, it can promote skin infection. You're allowing the opportunistic microorganisms to enter into the skin. All right? Soaking for 1 hour is not recommended. If you answered letter C, apply callus remover to corns and calluses on a diabetic patient, this can actually would lead to skin breakdown as well. Skin breakdown. And the same thing will follow, infection. We don't want that in this patient. They are very hard to treat, especially when they have wounds. That small wound can develop into a bigger one if they are not really careful in treating their wounds, and if they are not very conscious in managing their blood sugar. They need to have a podiatrist, guys. This will require a podiatrist. And this will apply to any diabetic patient, especially if it involves foot care. If there's any kind of appearance of corns, calluses, any blister, yes, they need to see a podiatrist. This is the recommendation for diabetic patients. If you answered letter B, use heating pads on low heat settings. Remember that our patient has sensory neuropathy. They will not be able to really feel the intensity of that temperature. So, in general, the use of the heating pads in patients with diabetes is to be avoided. And we do not want them to have burn injuries. This is something that we should be mindful about. Use of heating pads is generally avoided, especially to a patient with sensory neuropathy, because this can lead to burns. So letter A, opt for flat-soled shoes made of leather. What's the rationale on this one? It simply means that the shoes is well-fitting, and the characteristic leather, it can also prevent foot injury. It can also accommodate the changes in their feet due to the neuropathy and poor circulation. Much more of flexibility. So the correct answer here is letter A. Let's have number 13. Which patient information should prompt the nurse to consult the healthcare provider before administering metformin? Is it A, blood glucose is at 170 milligrams per DL, or B, scheduled for a chest x-ray in 1 hour, or C, a weight gain of 2 pounds in 24 hours, or D, blood urea nitrogen level is 52 milligrams per DL. A real leather, generally it is acceptable, not too hard, AJ. Compared to those synthetic materials. Which patient information should prompt the nurse to consult the healthcare provider before administering the glucophage? Would that be A? If you answered letter A, blood glucose that is 170, it's not a contraindication, but rather a blood sugar that will be fitting for this medication. It is slightly elevated, right? But not dangerously high. So we are not going to select this one. If you answered letter B, scheduled for a chest x-ray in 1 hour, is there such a contraindication? It doesn't. There's no interference with the use of the metformin and also the diagnostic test, chest x-ray. No known interaction. What about letter A or letter C? A weight gain of 2 pounds in 24 hours. This is a slight weight gain, but it's not directly relevant to the use of the metformin, unless it recall the level of your patient's blood urea nitrogen normal range usually sits around 7 to about 20 milligrams per DL, right? It's highly elevated right now. It's 52. That simply means that the patient may have possible renal impairment this time. And this metformin is also contraindicated in a patient with renal dysfunction. Take note, guys. Alert, alert. Metformin should not be used in renal impairment. Used in patients with renal dysfunction. Or let's say creatinine that is already elevated. That's another thing. The patient here can possibly develop the lactic acidosis. This is the complication when the patient takes the metformin, and if their renal function studies are high, let's say high creatinine, high blood urea nitrogen, they can develop the lactic acidosis. So that is a correct answer this time. Letter D. Let's have number 14. When preparing type 2 diabetes patient for a scheduled coronary angiogram, what information might lead the nurse to delay the procedure? Is it A, a recent hemoglobin A1C reading was 6.5%, or B, current blood glucose level is 128 milligrams per DL, or C, metformin was taken today, or D, captopril was taken this morning? Your answer, please. A patient that is type 2 diabetic is scheduled for a coronary angiogram. Angiogram. What information might lead the nurse to delay the procedure? Yeah, you answered letter C. That is the correct answer. Take note that when a patient will be scheduled, if they're scheduled for this procedure, angiogram, remember that it involves the use of the contrast media, right? That contrast media can also lead to impairment in their kidney function. And so if the patient missed, or let's say they did not really follow the instruction, if they took the metformin instead of holding that medication for at least 2 days, then it is wise for this nurse to actually delay the procedure, make sure that the medical provider is aware that, hey, your patient is taking the metformin today and he's supposed to have the angiogram, coronary angiogram today. And so this would really help the patient not develop the complication of lactic acidosis if the procedure is delayed. So make sure that you're going to investigate about the medications that they're currently taking. All right? The answer is letter C. If you answered letter A, recent hemoglobin A1C of 6.5, 6.5 is actually one of the target goals for good diabetes control. Not necessarily gonna delay the procedure. No contraindication at all. If your patient has a blood glucose of 128, it's slightly elevated. There's no contraindication. There's no necessity to delay the coronary angiogram. If your answer is letter D, captopril was taken this morning. Captopril is an ACE inhibitor. It is an antihypertensive drug. It will not interfere with the angiogram, and there's no reason for you to delay the angiogram for this patient. Okay. Metformin taken today. Remember about the lactic acidosis plus the contrast media. This can worsen their kidney function. Impairment of renal function. Let's have number 15. We're almost through. Which action by a patient demonstrates proper understanding of how to use glargine and regular insulin? Is it A, takes glargine 30 minutes before meals? Or B, family prepares a weekly supply of pre-filled syringes with both insulins? Or C, disposes of open glargine and regular insulin vials after 4 weeks? Or D, mixes regular and glargine insulin in the same syringe before administration? So you're going to look for that option that reflects understanding in the proper use of the glargine or the Lantus and regular insulin. Short acting and long acting insulins are actually part of the treatment. So if you answered takes glargine 30 minutes before meals, we know that the glargine is going to take effect for the total 24-hour period, right? It's a once a day dose, but it is not going to be taken before meals. What is taken before meals is basically the short-acting regular insulin instead. Should be taken before meals. Not this one. There's no need to do that. We know that the glargine can be taken anytime during the day. If you answered letter B, family prepares a weekly supply of pre-filled syringes with both insulins. It doesn't really answer that question. They should not be mixed or stored together because this can affect the stability and also the effectiveness of each type of insulin. Again, should not be stored together. If you answered letter D, mixes regular and glargine insulin in the same syringe, no, that's not the best practice, guys. We are not going to have them mix the regular insulin and the Lantus. Because the reason for that, it's they have differences in their pH. Different pH levels. So if you're going to mix them together, this can affect their absorption and also the action of each insulin. So do not mix them together. The correct answer here is to dispose of open glargine and regular insulin vials after 4 weeks. This is the best practice. They should be tossed 4 weeks after they have been opened. Even if there are some more medication left in the vial, that's not really going to be a safe thing for them to store more than 4 weeks. Okay, they should be discarded past that deadline. Okay, they should discard them, even though there's still remaining insulin in those vials. And that's why it's very important for them to really label the vial, make sure that they will put in there the date when they opened that vial. Make sure that they practice that. Okay, the same thing happens with in the acute care setting. That's always been a practice. We always label the opening date and the date of expiration, and that's usually 4 weeks after the date of opening. Let's have number 16. During a first prenatal appointment, a 29-year-old pregnant woman with a diabetic mother but no personal diabetes history visits the clinic. What is the nurse's next step? A, educate on using regular insulin. B, arrange a fasting blood glucose test. Or C, discuss increased fetal risk from gestational diabetes. D, schedule a glucose tolerance test at 24 weeks. First prenatal appointment. 29-year-old pregnant patient with diabetic mother but no personal diabetes history visits the clinic. So what would be the initial step the nurse should plan on doing? Would that be A or B? Or is it C or D? The pregnant woman's mother is diabetic. The patient is not. Okay? What the patient stated is that in the scenario, it states that their mother has a history of diabetes, but the patient is not, they don't have any history of diabetes yet. So what would be that correct option? If you answered letter A, educate on using regular insulin. Why would you educate this patient about regular insulin when you don't have any established diagnosis yet? There is no known diagnosis yet. The patient is not diabetic at this point. There is no established diagnosis in this scenario. So there is no need or no necessity for you to instruct this patient about regular insulin administration. None. If you answered letter C, discuss increased fetal risk from gestational diabetes. We know that the patient is at risk to developing this one, but the specific concerns depend on the actual test results. We want to confirm this by arranging a fasting blood glucose test first. Okay? Then after that, we can proceed with letter C. That's the appropriate time for this nurse to discuss about the increased fetal risk. All right? We need to know first if the patient really has the gestational diabetes. If you answered letter D, schedule a glucose tolerance test of at 24 weeks. 24 weeks. Your patient is actually there for their first prenatal visit. If you're going to do the glucose, if you're going to schedule them for the OGTT, this is a standard testing, especially for the high-risk patients, and they will require evaluation. But first things first, we need to identify first if the patient really has an elevated blood sugar. Then after that, we're going to have to proceed with further evaluation, possibly the OGTT. Okay? So, again, the scenario did not mention anything about the patient's history of diabetes, but her mother has diabetes. We don't have any clue yet this time if they really have a diagnosis. So first things first, we need to recognize that they need a screening. Early screening is important, which is basically scheduling them for a fasting blood sugar. That's the primary test that they should undergo. Okay? Let's have number 17. I actually prepared so many questions for today. What detail from a patient's medical history should the nurse report before an oral glucose tolerance test? Is it A, the patient uses birth control pills? Or B, the patient exercises regularly? Or C, the patient has been pregnant 3 times? Or D, the patient has a family history of diabetes? What detail from a patient's medical history should the nurse report before an oral glucose tolerance test? Is that A, B, C, or D? All right, guys, if you answered letter D, the patient has a family history of diabetes. Yeah, a family history can indicate their risk of developing the diabetes, but it does not really impact the oral glucose tolerance test validity. It does not. All right. It can place them at a higher risk. But then again, we are asked about the possibility of maybe an interference, maybe a false high or a false low reading. That's what this question is asking. Okay. All right. We are going to identify if the OGTT would be accurate if they are having that kind of lifestyle. So what would that be? The correct answer is the use of birth control pills. That is the correct answer. The reason for that is because the oral contraceptives can elevate the oral glucose tolerance test values. Yes, this can increase the OGTT's result. So this will be inaccurate. Very inaccurate. So take note. Make sure that you are going to report this to the medical provider, okay? That your patient takes oral contraceptive agents, because this will not be a reliable testing for them if they will use birth control pills. All right? All righty. Letter B, the patient exercises regularly. Is that going to be a contraindication, or will it affect the validity of the OGTT? I don't think so. There's no such restriction about their exercise. What about letter C? The patient has been pregnant 3 times. Will that impair or will that compromise the validity of the OGTT? Will it cause a false positive or false negative result? I don't think so. It can provide a context about gestational diabetes, but it does not affect the OGTT validity. All right. So B, C, D options are all incorrect. The reason for letter A, it can lead to an increased OGTT result. It will deem this testing inaccurate. Okay. Number 18. A patient with type 2 diabetes is scheduled for a cholecystectomy. Which task is appropriate for the nurse to assign to a licensed practical vocational nurse? Is it A, report the patient's blood glucose levels and insulin doses to the circulating nurse? Or B, explain the use of insulin during the post-op phase to the patient? Or C, administer Lispro insulin to the patient before surgery? Or D, develop a plan to prevent blood sugar fluctuations after surgery? you're going to assign a task to the LPN or LVN. So which of these tasks would be appropriate according to their scope of practice? Your patient is scheduled for a cholecystectomy. All right. I think we have this kind of type of test in the past regarding the scope of practice, right? Guys, you're only going to delegate those tasks if it doesn't involve comprehensive assessment, it doesn't involve the planning of the care, and also the teaching part and coordinating with the healthcare team members. All right. So those are the tasks that you should keep in mind. Those tasks that will involve coordination with the other healthcare team members, teaching, planning, and also comprehensive assessment. Those are actions that an RN can do only. Okay, those are not the actions that is in the scope of LVNs or the LPNs practice. All right, let's have letter D. Develop a plan to prevent blood sugar fluctuations after surgery. Like I've said, the planning, developing a plan of care, it is going to involve a lot of assessment. So this is not appropriate for this LPN or LVN. The nurse should not delegate this one. Developing a plan, not appropriate. If you answered letter A, report the patient's blood glucose levels and insulin doses to the circulating nurse. What does that mean? If it involves communication, or let's say relaying information to other departments, it involves higher level of coordination and clinical judgment, which will also require the RN's training, okay? Reporting the blood glucose levels and insulin doses to the circulating nurse. Again, this will involve higher level of coordination. There might be some additional questions why this was done or why it isn't done. This will involve much more clinical judgment. So this is not appropriate action for the RN to delegate to the LPN. If you delegate them, letter B, explain the use of insulin during the post-op phase to the patient. Explanation is part of the teaching. Detailed education is not under the scope of LVN's practice. Education with detailed information is not appropriate. It will require a much more comprehensive knowledge, also understanding about the mechanism, the drug action, the adverse reactions that they need to watch for. It's not appropriate for this LVN. So we will select letter C, administer Lespro Humalog insulin to the patient before surgery. They can do that. All right. It is a task that is within their scope of practice. They are trained to do the administration of medications, including injections. And this is not really complex. Hello, Pushpak. Welcome to the class. So the correct answer here is letter C. Let's have number 19. A 30-year-old patient has just been diagnosed with type 2 diabetes. What is the appropriate timing for scheduling a dilated eye exam? Is it A, every 2 years, B, immediately after diagnosis, or C, when the patient reaches 39 years old, or D, within 1 year of diagnosis? Your patient, who's a 30-year-old, has been recently diagnosed with type 2 DM. So what is the appropriate timing for scheduling them into the dilated eye exam. This is very important, guys. Eye care in diabetic patients. Would that be every 2 years? Will that be immediately after diagnosis? Or is it C, when the patient reaches 39 years old? And D, within 1 year of diagnosis? What you should select here is something that can promote initial assessment in a timely fashion. Okay? What we need to do here is basically to have a timely assessment evaluation to prevent complications. If you answered letter D, within 1 year of diagnosis, we know that the 1 year time span within 1 year, yeah, that's probably a maybe another option, but would not really gonna detect any existing or an ongoing issue with their eyes. Okay, this is going to miss out the opportunity of early detection. Can miss early detection. Because if they're just allowed to within 1 year, it could be 8 months after the diagnosis, 9 months, or it could be 11 months after the diagnosis. This is not going to allow an early detection, because we know that eye problems can actually happen within a year span. And so we are not going to select letter D, not the best option. If you answered letter B, immediately after the diagnosis, that is the recommendation for the eye care in the diabetic patients. It should be done immediately after the diagnosis to check for diabetic retinopathy. Early detection of diabetic retinopathy. This is huge, guys. Yeah, which could already be present at the time of diagnosis. If you answered letter A, every 2 years, actually the recommendation is not every 2 years. It will be annual, yearly. This is incorrect. Annual eye exam, not every 2 years. If you chose letter C, when the patient reaches 39 years old, that's 9 years after the diagnosis, your patient probably has already developed the chronic eye issues. They probably have the diabetic retinopathy already. So this is not going to help the patient. The best answer here is to make sure that they undergo the eye exam right after the diagnosis. Okay? After that, the annual examinations will follow. This is the recommendation, guys. Please take note of this. Eye care. Let's have number 20. After starting metformin therapy, an 82-year-old patient with newly diagnosed type 2 diabetes has a home health nurse visit. Which finding should the nurse urgently report to the healthcare provider? Is it hemoglobin A1C? 7.9%. Thank you, Chi-Chi. Right. That's kind of ridiculous when they are just watching and not even appreciating the lecture. Okay, that's letter A. Letter B, the last exam was over a year ago. Or C, decreased glomerular filtration rate. Or D, the patient has dietary restrictions. So your patient, after starting metformin therapy, they were taking the metformin, right? 82-year-old, 82-year-old patient. That is a good information, especially a patient taking metformin, an older person. So which of the finding here that would require you to urgently report to the medical provider? Would that be letter A, hemoglobin A1C of 7.9? 7.9 A1C is actually suboptimal. Goal. Not a life-threatening issue. So there's no really need for us to urgently notify the medical provider. Not life-threatening. So we are eliminating letter A rather. If you answered letter D, the patient has dietary questions, would this require you to call the medical provider for those questions? We know that they should be educated, right? But it doesn't really require you to call the medical provider right there and then. This is something that you can actually answer, right? As a registered nurse, you should be able to answer the patient's question about dietary aspects. If you answered letter B, the last exam for their eye was over a year ago. Well, if it was over a year ago, then maybe they can have another eye testing within the time frame. So we are not selecting. If you had letter C, decreased glomerular filtration rate, remember about the metformin? Yeah, this can lead to lactic acidosis if they have renal impairment. That is the correct answer. Decreased glomerular filtration rate. This answer, letter C, will require a maybe immediate discontinuation of the medication because of their risk to developing the lactic acidosis. Okay? You gotta notify the medical provider right there and then. If you noticed that their GFR is decreased, that one, GFR, or it could be increased creatinine, or it could be increased blood urea nitrogen. Those are the things that you should be looking at when you are concerned about renal function for those patients who are taking the metformin. Reduce GFR, increase creatinine, increase blood urea nitrogen. Or let's say decrease creatinine clearance. That's another one. All righty. Correct answer is letter C. How will the nurse know this during this visit? Okay. Well, with the home health visit, some others may have the capability of actually reviewing the medical records of the patient. They will have access to the computer system remotely, probably around this time when they are looking into the medical record, reviewing the patient's lab study, maybe from a prior clinic visit. Maybe they had the blood drawn prior to the visit. Then this is something that you can actually access remotely in the home setting, right? And yeah. How will the nurse know this during this visit? So that's a, I hope that this answers your question, Chi-Chi. But then again, some have the capability of accessing the medical record through remote access. Okay. Alrighty. Let's have number 21, which is the last one. I'm actually had it a little bit like over 20. After giving an alert diabetic patient 4 ounces of orange juice for a blood glucose level of 60 milligrams per DL, their blood glucose is now 65 milligrams per DL. What should the nurse do next? Is it A, provide another 4 to 6 ounces of orange juice, or B, administer glucagon 1 milligram IM, or C, give peanut butter with crackers, or D, notify the healthcare provider about the low glucose? Thank you. Take note about the range of your patient's blood sugar. Initial is 60. The subsequent reading is 65 milligrams per DL. The scenario that we had yesterday was quite different. Their blood sugar has actually been restored to a much greater value within the normal range, which is already stabilized. This scenario, your patient still has a blood sugar that is less than 75, despite the first dose of orange juice. Your patient's blood sugar is still low. This is still considered hypoglycemia. All right, let's do the rationale. Yesterday's case was totally different, guys. Please take note. That was a totally different case. The goal about the peanut butter yesterday was to stabilize, or it will not be the use of the peanut butter yesterday was actually to evenly stabilize the patient's sugar. It will not cause an elevation because it's already been in that safe range. But this time, our patient's blood sugar is still low, hypoglycemia. The patient is alert this time. Please take note. Your patient is alert, can take oral glucose this time. So if you answered letter D, notify the healthcare provider about the low glucose. We can do the notification after we have already treated the patient. What we do first is to attempt to resolve the low blood sugar. So treat the hypoglycemia first. Then we can do the notification. If they persist to not respond to the treatment, and that's the time to notify. Notify MD if patient's hypoglycemia is not resolved. We can do the notification after. So this is incorrect. If you answered letter C, give peanut butter with crackers. We can do the administration of the complex carbohydrates and proteins only if their blood sugar has been stabilized already. Complex carbohydrates and proteins. This is indicated, guys, when your patient's blood sugar has been stabilized already within the safe range. All right, please take note. Our patient is still not in the safe range. They are still hypoglycemic. So the better option, or the best option here, is to give them another dose of orange juice. We really want to get that blood sugar up into the normal range. That is the principle. Have you heard about the what we call this a rule of 15? Have you had this way back in your nursing? Rule of 15. What does that mean? Have you encountered this regimen? What you're actually going to do here is when you initially check the patient's glucose, especially if they are already hypoglycemic, right? On the first assessment, if they are below that 75 milligrams per DL, then what you're going to do is you're going to administer a fast-acting carbohydrate. And then you're going to follow up that with checking their blood sugar. And then you're going to give them another dose of the 4 ounces of orange juice if their blood sugar is still going to be lower, okay? They need to get another dose if they are still hypoglycemic, less than, that's 15 grams of carbohydrate in 15. Yes, that is correct. And so that's the rule of 15. If they are still not going to be within the safe range after the second dose, we're going to have to repeat checking their blood sugar one more time. And then we will give them another dose of that 4 ounces of the orange juice. Why it hasn't responded yet? We don't know. We don't have that information in the scenario. It could be that the patient has taken way too much insulin. We don't know. It's hidden in the scenario. It could be that they have taken a large dose of insulin prior to this hypoglycemic episode. And so we are going to follow that rule of 15 up until they will reach to that safe range. By the time, if they are not really going to improve, if they are still hypoglycemic, then that is the time for us to notify the medical provider. Probably they will require the injection of the glucagon, or if their level of mentation will change, if they will not be able to take anything by mouth anymore, if they're not safe to take any oral glucose, then that's the time probably the medical provider will order the administration of D50. But then again, our role here is to do the rule of 15 to stabilize this patient's low blood sugar. Okay? Take note, guys, our letter C is only intended when their blood sugar has already been stabilized. Okay? The use of complex carbohydrates and protein is only effective if they're stable already. Okay? But before that, if they're still hypoglycemic, we're going to do the rule of 15. All right, so that is the end of our exercises today. I hope that you are learning from these drills. So I'll see you again tomorrow. We'll be talking about the hyperthyroidism. So stay tuned for more news. I'll see you again tomorrow. Have a great evening, morning, night, wherever you are. You all take care, guys. Bye-bye.